Christy Ross has something that she put into the chat. So let me just read it to you. She'd like to hear your experience in getting equipment approved at the time of discharge without a formal sleep study. And she's in the pediatric population. And they're mainly people with neuromuscular disease and chronic hypoventilation related to other things. But how do you get them in the transition from hospital to home? And what do you think we should be talking about?
Well, I have to agree with her that it is quite painful, and you have to go through all these hoops to get it approved based on the silly RAD respiratory assist device criteria that the CMS put out now more than 20 years ago, which are obsolete. So part of it is what we're trying to do is to advocate for the CMS to change our criteria of how we can provide support to our patients. I think what ends up happening sadly and frequently is many of us as clinicians, and I'm guilty of this as well, is we try to label the patient as chronic respiratory failure, which they do have, to be honest with you, but we try to label them as chronic respiratory failure and try to approve them for expensive home ventilators like Trilogy devices and Astral devices. And for those of you who may not prescribe a lot of those devices, when you prescribe a home mechanical ventilator non-invasively, in this case a Trilogy or an Astral, these companies, the DME providers, love it because they charge the insurance $1,000 per month roughly while the patient is alive for perpetuity until the patient dies. That's a lot of money. And since the RAD guidelines are so confusing and difficult and create so much headache and pain for the clinicians and for the patients, the clinicians want to do good for their patients and they prescribe more of these, to the point that now the prescription of home ventilators has gone under scrutiny. And every time there's a spike in these expensive devices, the government puts it under scrutiny, trying to rule out there's no fraud going on. And I think, I wouldn't consider it fraud because, you're trying to treat your patients, appropriately, bypassing the stupid RAD criteria. And that's one of the reasons we're trying to push Medicare and Medicaid and advocate for better criteria. So in the meantime, we're stuck. We have to do all these silly assessments and qualify patients either in the neuromuscular group or restrictive group or the hypoventilation group or the COPD group to give them devices that they need. And that's one of the reasons. So I don't have a good answer other than saying that I sometimes feel like I'm breaking the law by prescribing a device that I think they need. But the point here is that if the RAD criteria gets modified as we're pushing for it, one of the arguments we're making to Medicare, because we met with the Medicare people and we presented our arguments. The argument that I presented for the hypoventilation subgroup was, listen, a lot of the doctors and providers are prescribing these expensive devices because you give them no choice. If the criteria are modified, many of these patients can get discharged with bilevel, with a backup rate or a regular AVAPS device or IVAPS device. They don't need a Trilogy. They don't need an Astral. So if we modify the RAD criteria, Medicare may actually save money and patients may actually get better care. Patients who are hospitalized that need to be discharged. So that's kind of the balance we're trying to strike. It's hard to convince because you're dealing with administrators. They look at the science, but they're not your peers. So you have to somehow convince them. And the way we did these presentations to the Medicare group was presenting cases of frustration of, okay, here's a case that I saw in the hospital, a patient with suspicion for OHS. And we had to do this blood gas, that blood gas, to the point that the patient said, I don't want to allow you to do any more blood gases because it was difficult to get ABGs with their body habitus. And then we couldn't get spirometry in the hospital. And the patient got discharged, couldn't come to the clinic because of transportation issues, and got multiple admissions to the hospital. until somebody prescribed a Trilogy device. So when you argue it that way with these administrators, then I think they may understand and make changes and agree with our recommendations. Because as I said earlier, Kingman, we're making recommendations to them. They're non-binding. They don't have to listen. They may say, okay, well, forget it. We're going to keep the RAD guidelines the way they are. So I think is essentially advocating and changing is going to the legislators, which we're doing, and trying to advocate and change the guidelines. That's what we're trying to do. In the meantime, you know, we do prescribe Trilogies and Astrals, which, you know, I don't think is appropriate, but what else can you do, you know? Long-winded answer.
Yeah, well, thank you. Yeah, no, this is Christy. Thank you very much for doing that advocacy. It's incredibly frustrating. It just eats up so much of our time. So I appreciate that you're working on it. And in pediatrics, sometimes we do need Trilogies just because the little kids can't trigger the non-ventilator devices. But when we don't, it is just yeah, it's very frustrating. So thank you for your work and excellent talk. I really enjoyed it.
And you bring a good point. You know, people who have neuromuscular disease, they are a different group as patients with OHS. I think in that subpopulation, I think devices like Trilogies and Astrals are actually many times a necessity. You're right, because they're so weak. So, and they need other assistance, and they actually need the respiratory therapy support. You know, just for those of you who don't prescribe a lot of these devices, when you prescribe a home ventilator, it comes as a package. The respiratory therapists don't charge. They do multiple visits to the home. So it's a comprehensive therapeutic approach, which many neuromuscular patients and pediatric population benefit and need. The argument we're making is that many other patients, for example, people who have hypercapnic COPD, people who have adults who have OHS, don't need all that. They may just need bi-level with a backup rate or AVAPs. So yes, let's clarify which patients need all the respiratory support and these expensive devices like neuromuscular patients, and let's clarify which patients don't need it. So not everybody, so the system doesn't get abused essentially.
Hey, Babak, this is Dennis Ockley. How you doing?
Good, Dennis.
As a good, great talk. Hey, get a couple of quick questions for you. You and others made me a believer in this quite a while ago, and so as all the sleep fellows can attest, I pay very close attention to bicarbs. You know, as you mentioned, most patients don't have blood gases in their charts. But one of the issues that always comes up, I always look back like the last year or two what their bicarbs are, and you'll see this huge range sometimes for some of these patients. So, you know, 24 to 32. And so what do you make of that, and how does that influence your management?
Yeah, that's a good point. I just ran into this recently. But sometimes, and again, I'll be honest with you, it's not all the time, but sometimes what I notice is that the higher bicarb levels coincide with the hospital admission and diuresis, or very closely after hospital discharge. And then eventually they plateau and normalize. Well, not normal, but they kind of stay at the higher level at the steady state. That's sometimes what happens. And I always tell people, before you put any weight on the bicarb, make sure the kidney function is normal, because you may run into a situation where patient has, you know, advanced CKD and they don't have the ability of reabsorbing the bicarb.
Right.
But again, I think that's one explanation that I have, but I'll be honest with you. And I think that's one of the, so the French group, you know, Jean-Louis Pepin and others have done nice work in this area in terms of looking at not just diuretics, but other medications that can impact, you know, bicarb levels. So their argument has always been that it's not just diuretics. Many medications can impact bicarb levels. So we have to be mindful of that.
Yeah. And then I have one other quick question, just, you know, the studies on BiPAP versus ASV. You know, first, just a comment that those pressures would be kind of average for our lab for the BiPAP settings. We have problems usually with the maxing out, but I noticed that there's a backup rate on all those studies. How strongly do you feel that that is needed, as opposed
well,
to?
let me clarify one point. The studies that compare bi-level with a backup rate versus AVAPs or IVAPs, I agree with you that many labs reach high IPAPs unfortunately, many labs also go up on the EPAP a lot. For example, there are labs where they say to techs, increase EPAP until there is no obstructive apneas, no hypopneas, and no snoring, no flow limitation. When you want to, which could be fine in the average OSA patients, but with a patient who needs pressure support, you may face a situation where the tech increases the EPAP to like 18, 19. And then once you get to that point, you don't have that much room for pressure support.
Yeah.
So the point that I'm trying to make is that in our lab, for example, I was struggling when I got to UFC, University of Chicago, back in 2006, how to train the techs to do adequate PAP titration. And eventually, one day, it hit me that instead of pushing them for EPAP, IPAP, and that, I would say, okay, let me explain to you what's the concept of pressure support. Once you understand the concept of pressure support, then when I tell you in my requisition, I want at least the pressure support of 10, then it's stuck. Because there's only two ways you can give pressure support of 10. You either have to go on the IPAP or go down on the EPAP, right? And then I can achieve what I want. But many times what I was seeing in our lab, at least years ago, was, they kept going up and the delta between the two pressures was almost the same. But you're right. I mean, if it, what I was trying to show in that study is that if it's done appropriately, then there's probably no difference between them. Now, in terms of backup rate, that's another interesting question, because years ago, I used to believe that these patients don't need a backup rate. Because when you look at patients with OHS in the sleep lab, they tend to be tachypnic, if anything. So at me, I would present that, my point of view, and many people that I respect, like Atul Malhotra, and many others, would argue with me that, no, I think, they do need a backup rate. And we always would get into this argument with David White and others. And their argument was that, many times when they turn supine, or as you're trying to aggressively ventilate them, they start having central apneas, which I didn't see much in my clinical practice back then. But then once they told me that, I started paying attention and I noticed, well, yeah, actually, if you do aggressive, titration of, pressure support, then yes, that can happen. The question that remains in my mind is, if you prescribe somebody with a backup rate, and just for the fellows so they know, once you go to the backup rate, you're talking about going from a BiPAP, which may cost $1,500, to a $5,000 device. So a backup rate is a big deal for the insurance companies because it's much more expensive. So the argument is that if they need a backup rate at that point and you give them a backup rate, how long is the backup rate getting activated down the road? Because I wonder if, and this is data that we probably have and I haven't looked at retrospectively. I'll be curious to see if, for example, the first few weeks, the backup rate is a lot, and over time, the backup rate goes down, suggesting that these individuals in the long run don't need such an expensive device and they just need, a regular BiPAP machine. I don't think there's been any studies comparing devices with a backup rate versus ventilation without a backup rate. I don't think that has happened so far.
All right, great. Well, thanks again. It's always a pleasure to hear you speak.
Thanks, Dennis.
If I was there, can you put a person on a trilogy for 3 months?
Yeah, good question.
So just don't fight it, just go for that and then take it away.
Yeah, well, the Office of the Inspector General, I don't know if you saw that letter or not. Recently, they actually published a letter, and when you read the letter, you get a little nervous, as a practitioner prescribing trilogies. And at the same time, that pressure is going to be placed on the durable medical equipment provider companies as well. So I think we're going to get more and more difficulties prescribing it. What we are proposing, so when we had...
I'm just thinking about what you do now.
Yeah. So now is a good question. I don't know. But this is what we're proposing to Medicare. And when we went with Medicare, other stakeholders were there. So DME providers were there, the CMOs of
Right.
Onyx and ResMed were there. And what we argued to the industry was on your AVAPS and IVAPS platform, also add auto EPAP so that you don't have to use Trilogy or Astrals. Because right now, if you just want to prescribe AVAPS or IVAPS, they don't have auto EPAP feature. That's only available in Trilogies and Astrals.
Yeah, well, they don't give it to you, but it's in the chip. They only have one chip for all the machines.
Exactly. So they can easily modify this. And the idea, what we're proposing to Medicare, if they approve it or not, is when patients get discharged from the hospital, since we don't have polysomnography on them yet, allow us to prescribe automatic NIV or bilevel with a backup rate.
Right.
And then we see the patient within 3 months. At that point, they undergo polysomnography, and many of these patients can be switched to CPAP. And that's what we're proposing. And we're proposing in the first 3 months, patient may benefit. In the long run, you may not have to pay, on a rental basis for 13 months for an expensive device. We can switch them to CPAP, so you save money and hopefully they don't get readmitted and so on and so forth. The other option is, as you said, is prescribe them a expensive Trilogy device as they leave the hospital and then bring them in and return that device and give them a regular device. Yes. And I've done both, to be honest with you. But until they push you to do something, most of us are not going to do this in clinical practice. I think what's happening in clinical practice nowadays, sadly, is many of us prescribe the Trilogy or the Astral while they're leaving the hospital. And then, things fall through the cracks and you forget about it, or the patient doesn't show up and they stay with it for a long time.
Yeah, well, what happens here is that they don't even involve us.
Exactly. Yeah.
Home care company has somebody sitting in the office. The social work knows that this is what it is. They have a piece of paper that says you can get them out on a ventilator if you use these criteria.
Exactly. And I'll be honest with you. I feel like to some extent I have, at least in my institution, promoted that, because many times we get curbsided.
Yeah.
And we say, well, there's no good solution to this problem. Sometimes what I do is I say, let's arrange for this person to come to the sleep lab for a titration. So they get discharged from the hospital, but they don't leave. That same night, I get them to the sleep lab. But that's very difficult, right? Because you have a full schedule. Right. Other times I try to squeeze them into the clinic where my average wait time is 2-3 months. But frequently, you get so many of these that at some point you're like, well, gee, I can't deal with it. But you can bypass the system this way. And obviously the interns and the residents learn. The next time they don't call you, they just go for it.
They do. But then what happens is that they discharge for follow-up to sleep medicine.
Exactly. Yeah.
They don't discharge to follow-up to pulmonary, because
exactly.
Pulmonary says it's a sleep problem and you go, they're awake hypoventilation. So I don't see why you can't just take them off the Trilogy that somebody else put them on.
Oh yeah, definitely.
I think if that happens, then you just say, okay. So maybe that's another solution. I hate it when I get a Trilogy. Well, what happens? They get discharged for one week, and the home care company calls me up and says, "What's your settings that you want?" And I'm going, what patient, where, how?
Exactly. And I'll be, the other observation that I made, that I think the other study that I shared with you showed, is that interestingly, when you switch some of these patients from devices that have backup rates to CPAP, they prefer them. Yeah. And a lot of it may have to do with desynchrony with the ventilator. Right. Settings are not adequate. Many of these patients are not happy. They may use it, but this issue of desynchrony, particularly when the backup rate kicks in or epiglottic closure, I think is a real phenomenon. Right. And CPAP sometimes is much more comfortable for them.
Right. Okay. Well, we've kind of gone into 9:20, which is always what we do when we get exciting things, talking about things. And we can take a break here for about 5 minutes. People can do what they want to do and reconvene and talk about other issues, particularly more about this management issue. Okay?
Sounds good. I'll go and get a coffee.
Okay, yeah, get something, go to the bathroom, whatever people have to do. Bio break, I guess, is the preferred.
There you go.
Right, okay. There we go. So I'm back. Hello, Eric.
It's crazy out here.
Yeah, just be careful.
Can't even find a good place to park. But that was really good. I mean, I was wondering if we could, get that slice back, and then I'm gonna put this, kind of edit it and then put it on a YouTube channel or something like that. I mean, I think that's definitely a very, very good question to think about. And then, especially, I think that comparison to mortality rate at 3 months and 6 months was shocking.
Right.
It was shocking. It was just like, wow. Yeah.
I think that's a reason to do it, but again, you need to have the bandwidth.
Yeah. All right. Let me try to park in here.
So Babak, I'm one of the people that uses progesterone about once every 2-3 years. I bring it out because I used it when I was a fellow and a bunch of patients. So that's cute.
Yeah, and then you still bring it up from time to time. He's like, "You want to give this guy progesterone?"
Well, we just talked about a patient that came out, a pitiful came out. But its half-life is 72 hours. So why do they give it 3 times a day? That's ridiculous. So you give it once a day. It takes about 7 to 10 days to have an effect. And while they did stop it, and they showed that it reverses, I've had some people who have, if they've lost weight and they've gotten better, that and they're treated for their CPAP. And
Right.
there are formulations that Upjohn used to have that had very little effect on, had all of its effect on the brainstem and not any effect on other sorts of things peripherally. So that depends on what your affinity is for what receptors where. But there's basic science there. But no one was particularly interested when I'll have to dig out my old grants on that. I didn't think it was worth thinking about.
Dr. Schroll, can you send more information on that progesterone and OHS therapy? I was talking to Nardine, and so she decided to go with just BiPAP. She said all the studies that she read, they talked about using CPAP or BiPAP along with progesterone for OHS. I mean, that's what we talked about as well, not just progesterone. But she said, let's see how this works. And she wanted to know what your reasoning behind it was or what you were referencing to.
Well, Babak pointed to the article that was from Denver. Now, what I was talking about is the Denver, the 20 milligrams TID, its half-life is 72 hours. So it's ridiculous to give it 3 times a day. And the other is, but I've used it for like a month or 2 months, and it's okay. It's okay. And what it was based on a study that we published in which we gave it, like most of the sleep apnea literature, we gave it to 9 people and 4 got better and 1 got worse, and 4 didn't change, and everybody said, well, it doesn't work. But on the other hand, if you could take 30 or 40% off the table, people off the table, and it increases their ventilation, increases their oxygenation during the day, decreases their nighttime hypoxemia nadir, and you use CPAP. At that time, 1979, we didn't have CPAP. So we were trying to prevent a trach. And so it seemed to, and I've used it a couple times over the VA, and everybody goes nuts. I mean, they go,
Well, it's interesting that you mentioned that because, again, based on your older studies, you know, in a subgroup of patients, you're right, even their OSA gets better.
Yeah.
And in the same thing goes with acetazolamide. You know, if the patient it falls in that endotype of more loop gain and whatnot, a population of those patients may also get better in terms of OSA and then in terms of OHS as well. But one thing I will note is in the studies where they used progesterone, one thing they did before they prescribed it was they asked the individual to hyperventilate.
Yes.
If they can drop their CO2 levels.
Right.
The reason is because if a patient cannot, if the patient has ventilatory limitation because their FEV1 is terrible and they have horrendous COPD, and they cannot blow off the CO2 like patients with OHS can, and you give them a respiratory stimulant, you're going to make them feel more dyspneic.
Yeah.
So that's one thing.
It was Dempsey did that for the hypercapnic.
Yeah, I had that slide, but I skipped over it for sake of time.
You know, I throw an oximeter on them and have them take 10 deep breaths. I take the 10 deep breaths with them and see what happens.
Yep.
But then you have to watch out because after you stop, they'll bottom out on you because they'll stop breathing. But that's a poor man's way of doing hyperventilation testing.
But it's interesting, you know, talking about the Denver study, that one I shared with you.
Right.
The senior author of that paper is Pearson, right? David Pearson, who, you know, as you know better, he moved to Seattle at that time. And I asked him, because we were in a meeting together once, and I asked him, hey, so I've always been interested in this study. How do you guys go about this? How do you know if those 10 men were tolerating it? And he said, you know, those were the 70s. We didn't ask those questions about erectile dysfunction and those sort of things.
Well, it goes away when you stop it, because that was the thing that they did.
Yeah.
And, I mean, I don't want to make it, I gave it to a few women, and you have to worry about the breakthrough bleeding when you start coming off it.
Mm-hmm.
So you have to do a GYN examination beforehand so that they don't go nuts.
And long term, I guess the concern would be also whether they can get a little bit more hypercoagulable.
Well, I mean, I
short term, you're right. I mean,
but I don't know if you know, the one. So again, what you're trying to do is get them over the hump of whatever they did. And the other thing I ask people is when they come in, as you note, they all come in with these different diagnoses: asthma, COPD, heart failure, pneumonia, whatever it is. Then they come out the other end saying, well, they have a deficiency of PAP, right? I mean, they sit there. So I asked the patients, you know, what were you like a month ago? And if they were going to the grocery store and they were able to do some things, they may have been short of breath. But a month ago, if they were doing pretty well, there was something else that tipped them over.
Yep.
And a viral illness will decrease your muscle strength by about 12 to 20%, which you and I would not notice. But people that have polio, that was studies that were done in polio victims and chronic polio, is that they dip their muscle strength. And I think that that's the other thing that happens. Now, although I'm worried, it makes me worried now that we have more numbers of the mortality in which at 3 months, if you don't send them out the door with something. So that was why I was thinking that you could, you know, why not let them do trilogy and then bail them out in the next month or so.
Yeah, I think that makes sense. One thing that, you know, when it gets to this whole, the way I used to think about progesterone or Diamox in terms of adjunct respiratory stimulation was, what do you do with individuals who you put them on CPAP or BiPAP for that matter, and they get better? Say if their average CO2 was 54, now it's, you know, 48, 47, but they don't entirely normalize despite having reasonable adherence. You know, should we then be pushing for something else? Should we go to more advanced modalities like volume targeted pressure support, or should we start thinking about Diamox or progesterone? But then after a while, I started thinking to myself, well, what's the long-term consequence of CO2s of 47, 48 versus 44?
So when I was coming in the early 80s, you weren't hypercapnic until your PCO2 was 48. And it had to be 48 on 2 separate occasions. You couldn't have just one value of 48, because we had done a study in which we had people that were 47, 48, 49, and had 2 blood gases within a month of each other, and they go one way, one side or the other. So if you, and again, the acidosis, mild acidosis, we did some work in submarines, in a submarine, to look at the effect of 1 month of chronic of 3% CO2. And it has an effect on calcium, mobilizing calcium, but it doesn't do anything to your breathing.
But in terms of long-term impact on, pulmonary vasculature, I mean, again, for such mild hypercapnia, I don't know if anybody knows what.
Because your oxygen's better. See, this percent time below an oxygen saturation of 90 is a convenient value, but when we published the way of sort of looking at that, it was the entire curve that was important. It wasn't just that. So that's what the hypoxic burden does, is it takes into account your baseline oxygenation. And in the late 80s, we were putting on an oximeter for 24 hours, finding that sleep apnea was not confined to the usual hours of 10 o'clock at night to 6 o'clock in the morning. So it's really your cumulative daily dose. And the other was Bradley's work that thought that you had to have some intrinsic lung disease or heart disease to have polycythemia or pulmonary hypertension. I don't know. We found that 20% of the time below an oxygen saturation of 90% gave you a small increase in erythropoietin in fairly obese sleep apnea patients. But it wasn't a spike like you find with cyanotic heart disease, or you find with going to altitude. It's not a huge spike. So you adjust to it. Okay, fellows.
My observation, as I was saying earlier, is that most of these patients, if anything, their hemoglobin tend to be on the low side.
Right.
And I wonder if that is anemia of chronic disease.
We did one with Hofstein. He took about 400 people that weren't on any medications and looked at their hematocrit according to their severity of OSA. And certainly if your OSA was like 40 or 50, your hematocrit was higher. But if you didn't, the hematocrit was 41. And if you had severe OSA, it was 43. So you go, okay, all right. So let's see. We got the fellows here: Zach Stumpf, Omar Jadot, Anupam, and Maduri are on. These are the 4 fellows we have. Zach and Omar are looking at pulmonary critical care stuff, and the other are internists. And we're agnostic in terms of where they come from. We just want good athletes, and so these guys are all trying to do this. So do they have any questions here?
Yeah, hey, Dr. Mokhlesi, thanks for the very interesting talk. I had a question about, you mentioned earlier at the beginning of your presentation, sort of pretty convincing evidence that we're missing these patients, these OHS patients in different settings, underdiagnosing, undertreating. Do we have any sense of where we're missing them? Like, where are these patients presenting? Is it the ICU when they're finally on NIV or intubated? Is it in the clinic, before they have clinically evident disease? Where should we target, kind of resources to diagnose them earlier or catch them earlier? Do we have any idea?
Yeah, it's a good question. I think what I've described in the literature is similar to what I've seen in clinical practice. Again, every time I'm in the ICU, the average 2 weeks that I'm in the ICU, I think I get 2-3 of these patients that come from the emergency department, massively obese patients. While I'm in the ICU, I try to, the house staff know that I'm interested in this and they hook them up with me, but then when I'm not in the ICU, I never hear about them. I don't think they stop coming. So, so I think one of it is one good place to identify these individuals is the ED coming to our services, pulmonary critical care services. And one of the things I like about OHS is that is one of those conditions that people in the sleep world are involved with it. People in the pulmonary consults are involved with it or get involved with it, much to their chagrin. And also in the ICU we deal with it. So it's one of those conditions in the sleep world that covers all the spectrum of pulmonary critical care sleep. So I think that's a good area to recognize these individuals. And the other one I would say is in the sleep practice, particularly in the sleep lab, when you see severe, out of proportion hypoxemia during this sleep study, the challenge is that many places do not routinely do CO2 monitoring. So, obviously that's a missed opportunity. But again, I think the challenge is that, some people would argue, what's the point of getting a transcutaneous CO2 for every single room that I have if the device can cost me $20,000? I don't get any reimbursement for it. You cannot bill higher just because you have a transcutaneous CO2. And on top of that, if you're telling me that most patients with OHS have severe OSA and CPAP is equally good for them. So if I'm going to give them CPAP and they're going to use CPAP, you could be cynical and say, who cares, right? Right. The counter argument to that, in my opinion, obviously I'm biased, is that in general, I think these patients tend to have worse outcomes than patients with just severe OSA. So the way you manage these patients, the way you follow these patients, the way you may push for them to be adherent to therapy may be different compared to a regular OSA patient. So I don't have good answers, but I think the best two areas to recognize these individuals is, acute on chronic hypercapnic respiratory failure, which, as I said, these people hit the ED, and for some reason, everybody's labeled as COPD exacerbation, at least at our institution. Everybody's COPD. I mean, the moment your CO2 is elevated, you have COPD exacerbation.
Correct, right.
It's kind of a knee jerk, And the other thing that we run into frequently is, and this issue came up also with the Medicare criteria, in terms of how do we ascertain whether somebody meets criteria? And we get into this debate of, okay, many emergency departments do venous gases,
right?
And or they try to do arterial gases, but they obtain a venous gas.
Right.
At the oxygen levels,
Right, it's 20 or.
Yeah, when you correlate it with the oxygen saturation, it's venous.
Right.
And because it's just physiologically not possible. And a lot of debate has been going on. Well, the CO2 levels from a venous gas is not as accurate. And I accept that. And, but my argument is that, and this argument was also made to the Medicare people, that if a patient comes to the emergency department and the venous gas shows a pH of 7.15 and a CO2 of 100, what
else could it be?
Exactly. I mean, that's crazy to say we need another arterial blood gas.
Right.
An arterial blood gas on the patient's prescribed oxygen level. We need arterial blood gas, and we need the oxygen saturation below 88 for 5 minutes. I mean, all these stupid rules that they have make no sense.
Right.
So we can debate how accurate is a venous gas until the cows come home. But the question is, how do you explain and how do you put on paper and convince administrators? And that's where there's nuance, right? As a pulmonologist or a physician who understands physiology, you understand that with that pH and that PCO2, there's no question that this individual has chronic CO2 retention.
Right.
But now come and convince somebody who's looking and checking boxes to accept the device or not. So, but I would say the best way to recognize these people is in the ICU. And I would argue that those individuals who hit the ICU, which is a subgroup of these patients, not all of them,
right?
Those are the ones that you want to recognize because those are the ones who die more.
Right.
The ones who, as Kingman and I were discussing, the ones who have PCO2 of 47 and have an AHI of 80, do you call them severe OSA or do you call them hypercapnic OSA or do you call them OHS? I think it's semantics. What I care about is the person who has significant CO2 retention and altered physiology that is really leading them to get multiple hospital admissions.
Right.
And without getting recognized. Those are the ones who I think would benefit most from our interventions.
Yeah. And I guess the other thought is, I think just like you said, I think anybody who works in an ICU will if they're looking, we'll see those patients come in. But like you're saying, they always have a chart diagnosis of heart failure and or COPD, especially if they've smoked a cigarette ever in their life. And, and so I guess the other question is, if you're the clinician, what can you're in the ICU, maybe you don't have access to maybe the sleep lab. Like, what are some of the things you can do to help kind of sort things out on the inpatient side? Is it, thinking, should we be kind of ruling out heart failure? I'm trying to think of how do we kind of get the process started to label them as OHS, when we capture them in that high risk state in maybe the ICU or the wards?
Yeah, so that's a good question. And that's also some of the things that we're trying to advocate with the Medicare group. So one of the things we're advocating, and the reason I'm kind of segueing into what we're advocating for Medicare to change, because it represents what I believe. What we're advocating is to remove the criteria for spirometry for two reasons. One, in some institutions, it's hard to get inpatient spirometry, believe it or not. Second, some of these patients may have very mild obstructive airways disease, which could also be related to not parenchymal lung disease, but related to their obesity. Third, what we're asking them is, again, whether they accept it or not is a different story, but what we're advocating is that when a low clinical suspicion for COPD. So as a clinician, you say, look, this person is 45 years old. They smoked from 18 to 25. They have 7-pack-year smoking history, and they're 45 years old. They have no other exposures that would put them at risk for obstructive airways disease. Many of these patients, when they get admitted through the emergency department, at least in our institution, everybody gets a CAT scan with PE protocol. Right. So you have lung parenchyma that looks, other than some basal or atelectasis, essentially no parenchymal lung disease. Everybody has a TSH nowadays. You look at these people, they have no evidence of neuromuscular weakness, at least just grossly on exam. So you say, my clinical suspicion for significant COPD causing hypercapnia, neuromuscular disease, or mixed edema coma is low. I don't need a spirometry in this case. I don't need spirometry and PFDs to delay diagnoses and appropriate intervention. So don't give us a hard time. Let us intervene in this patient in an appropriate fashion, and let us discharge this patient with the right therapy. But again, I believe that, we in the guidelines, we framed it in such a way that it doesn't shut doors for future research, because that's my concern. I've heard people show my study saying that there's great evidence that patients who get discharged without therapy die more. I'm like, great evidence? I don't know about that. I would say it's very, very weak evidence. And we have to be cautious. And because when people advocate so strongly, then you can see how ethical boards, IRBs, are going to say, well, hold on. The guidelines suggest that you should discharge these people on therapy. You're providing substandard care to the group that is randomized to no therapy. And that's a challenge. So you have to strike a balance there. I think we need good studies, to be honest with you, before we make these broad generalizations that everybody should get discharged on BiPAP with a backup rate capability device.
Excellent. Thank you. Oh, Dr. Stoll, I think you're muted. It looks like you're trying to talk.
Yeah, okay. So the idea is point of care assessment. So I think the idea of having them, taking them off of oxygen in the MICU, just take them off and sit there for 20 minutes and take a look at them. I think the other is, and you can have them hyperventilate to see whether or not the O2 sat goes up. That's what I do in the clinic when I was doing more ICU. Another is you sit there and you go, okay, in the MICU, you got oxygen saturation, you have some measurement of effort, you have heart rate, and you have observations of position. Okay, and then they ask me for a portable HST, and I say, well, I've got oxygen saturation, I have an idea about effort, I've got a heart rate, and I've got position. What's going on? So write your note outside the room when the guy's asleep without oxygen on. And if it goes down below 90, 88%, see whether or not if he wakes up, it goes up. I mean, that's the sort of the post surgical sort of approach. The first thing is find out if it's related to being asleep or groggy or things of that sort. So I think there's an opportunity to put in some sort of breaks there. And then the idea about blood gases. I mean, our house staff are allergic to doing blood gases.
Yeah, I agree. I mean, you know, when the patients are in the ICU and they have an A-line, that's a no-brainer. You know, you can do a lot of things. But frequently this question comes up when they leave the ICU. Now they're on the wards. Obviously the A-line is out. And, you know, they're trying to figure out what to do. And, you know, I've had this situation, as I talked about earlier, that the patients are reluctant because the intern goes in digging for the artery, you know, sometimes without giving enough lidocaine, and it hurts. And patients many times refuse. And that creates hurdles, right? So that's why we're trying to advocate for, you know, understanding that there's limitations with venous gases, there's limitations with transcutaneous CO2, with end-tidal CO2. But if they're grossly abnormal, then why not put value on them? You know, we had this debate about end-tidal CO2. Say if you do a spot check end-tidal CO2, you have a portable end-tidal CO2 device that costs $2,000. And, you know, obviously if you have parenchymal lung disease, issues with dead space, different, you know, ventilation areas, particularly in COPD, you could have numbers that don't match your blood gas. The counter argument to that would be that if the end-tidal CO2 is low, you may not know what to make out of it. If the end-tidal CO2 is like 60, and the machine is well calibrated, then using the argument that, well, end-tidal CO2 may be low because the patient has parenchymal lung disease is a moot point because it's already elevated, you know. And then in that situation, do I really need to get an arterial blood gas just to satisfy an administrator?
Right.
If the patient meets, if your pretest probability for OHS is high, right, based on diagnosis of exclusion, the patient's clinical presentation, and then you have an end-tidal CO2 that meets that, then I would say that's reasonable to use that. And the other thing that I'll tell you is this: when, you know, I always talk about this when I talk about my research experience, I say that in one of the clinical trials where we were trying to enroll patients in the outpatient setting, and I showed 3 of those patients who were randomized to CPAP who failed CPAP titration and nonetheless got CPAP. For that study, people would come to the sleep lab, and I had bought an end-tidal CO2 monitor, you know, one of these known-in devices that cost like $2,000. And I would use that as a screening tool. So they would come, I'll do my history. I'm like, yeah, you fit the bill, put the end-tidal CO2 here, 52, 53, this is awesome, go for the blood gas. They would go for the blood gas. And they would come back pH 7.47,
right?
PCO2 of 44. I'm like, damn it. And then I had put the inclusion criteria. My inclusion criteria was PCO2 has to be above 45. I'm like, oh. So then I would tell the patient, hey, listen, I'm going to send you for another blood gas. Did it hurt a lot? So, yeah, it did hurt. And in our PFD lab, our PFD technicians cannot give lidocaine. They can draw blood, but they cannot inject. The moment you inject, you need a different level of license. Nurse. I don't know if you guys knew this or not. So most PFT technicians cannot inject lidocaine. They can take blood, but they cannot inject. Anyway, so then you start playing these games. So I told the guy, hey, listen, go back for the PFT for another blood gas. This is another day. End-tidal CO2 again, 54. And I said, when the guy's sticking a needle, if it hurts you, don't hyperventilate.
Right. Just relax.
again, you're gaming the system, right? The next blood gas came back 7.37, PCO2 of 52. I'm like, you're in. So you see how the point I'm trying to make is that the blood gas also has to be interpreted with, with caution and within context. And that's one of the problems we run into, because then the administrator is looking at, PCO2 of 45 and higher. How do you now explain to the non-MD administrator that, listen, this patient hyperventilated while the blood gas was being drawn? Normally their CO2 would have, if you adjust for the pH, their CO2 would have been 52. It's obvious that they're alkalemic, but anyway, so that's one of the problems with that. I think that's one of the limitations of blood gas potentially. A colleague of mine at County Hospital here actually did a study on that. And they showed that when you looked at end-tidal CO2 and blood gases in the PFT lab, that the great majority of patients didn't have evidence of hyperventilation. Now again, you could argue, well, how good was the tech? How easy were they drawing blood in these patients and whatnot? But anyway, that's one concern that I have with blood gases potentially.
I had another question. So you talked at the end of your lecture, you talked about how you can send the patient home with Trilogy and then bring them back, put them back on CPAP, and they'll tolerate CPAP better. I've only seen 2 Trilogy patients, and they got Trilogy while they were in the hospital, like a prolonged stay, 30 to 45 days for something. And they absolutely loved being on it. And when they were sent home, their sleep physician put them on either a BiPAP or a CPAP. And they felt as if they could not breathe at all. And they wanted Trilogy, but they did not, they didn't have ALS. They didn't have polio. They didn't have anything. So why? You said they tolerate CPAP better, but why didn't the 2 patients that I saw, they tolerated Trilogy better?
That's a good question. Keep in mind that Trilogy is one of those expensive devices that has CPAP capability, bilevel without a backup rate, bilevel with a backup rate, AVAPS AE, has all those options. You can put AVAPS in a pressure control mode versus no pressure control mode. And there's a lot of bells and whistles where you can adjust inspiratory time and other things to make it more comfortable for the patient. And to be fair, when patients get these expensive devices and the respiratory therapist provides a lot of support, because remember, there's a package. The respiratory therapist many times goes to these patients' home and keep adjusting the machine like they do with neuromuscular patients until the patient says, I like this setting. So many times I've had patients who, like Kingman said, somebody prescribes Trilogy, nobody knows who, and they pop up in your clinic. And the silly patient doesn't bring the machine because Trilogies tend to be a little bit heavier. So somehow, at some point, through a lot of pain, you have to get the download data, because Trilogies, now the newer devices, you can get them on Care Orchestrator, but the older versions, you actually need a manual download. And you get a download, and you notice that they're actually on regular BiPAP without even a backup rate. Mm-hmm. That expensive device is just a regular BiPAP. So what I would say is that if the patient, for example, has Trilogy and they're happy with their settings, there's no evidence, at least by clinical history, there's no evidence of dysynchrony, and they're doing it well, I would say take a look at what are the other settings that we usually as sleep physicians don't pay attention to. Inspiratory time, if it's a ResMed device, TI max, TI min, those kind of settings, and then try to emulate those on a regular BiPAP device, and chances are the patient will tolerate it equally well. And again, this is almost like neuromuscular. So what we do in our clinic sometimes is we have one of our techs there in the clinic. So I put the patient on the exam table, I lower the head of the table like the neuromuscular patients, put the mask on their face while they're awake. And I'm saying, okay, so tell me, do you like, it's almost like when you go to the optometrist, this or this, this or that. And then you just play with different settings until they say, oh yeah, I like this, But that takes time and effort. For a 15-minute visit, it's tough to achieve those, And I can see why many people on the pulmonary side would be reluctant to deal with these patients, because they don't have familiarity with the devices. I mean, I would argue this is more of a pulmonary problem, not a sleep problem. But again, these patients usually get pushed to the sleep clinic. Now imagine if you're a sleep neurologist, you might not feel as comfortable. And that's what happens in our practice, because the people who schedule patients to the sleep clinics, the schedulers, they don't know which patients should go to who. So I see narcoleptics, I see RLS, I see everything, which is good. But sometimes I think, a very difficult RBD may be better handled. If I'm having trouble, I may internally refer that patient to my colleague in neurology. But these individuals who schedule these patients don't know any better. So that patient on a trilogy may go to my colleague in neurology, and the poor guy calls me like, dude, help me. What do I do with this patient? But yeah, I mean, those are the challenges that we face,
Thank you.
It's almost like the Second Amendment, don't take away my trilogy. Because the patient also has this preconceived notion that this is the best device with all the bells and whistles, like Charlton Heston said, out of my cold dead hands, you're not going to take it away from me.
Good. Anything, Madhuri?
Yeah, I have a question. So you mentioned person with higher CO2 at the baseline may not respond well to CPAP alone. But we always try with CPAP. How do we identify that population to begin them on BiPAP?
That's a great question. So I wish I knew, but I'll tell you this. Many labs don't do transcutaneous CO2, but let me go back for a second. If I was trying to convince you guys that many patients who remain hypoxemic on the ideal CPAP pressure may do well on CPAP in the long run. The same thing applies for CO2. So if you routinely monitor transcutaneous CO2, you will note that some of these patients, as you crank up the CPAP pressure and you splint the airway open, sure, they remain hypoxemic, and many of them also, they have this rebound of REM, and they have some evidence of persistent hypercapnia. And you might say, oh, gee, look, this person is hypercapnic. Their hypercapnia is not going away. Forget about the hypoxemia. If they're still hypercapnic, let me switch them to a more aggressive mode of ventilation. Let me switch them to, bi-level with a backup rate or whatever during the titration night. The challenge with that approach is that the assumption is that if they remain hypercapnic while on CPAP, they will remain hypercapnic in the future as well. And I think many people have shown, including Kingman, that it takes time for the hypercapnia to get better. And it takes time for the chemoreceptors to improve their sensitivity to CO2 changes. So my experience has been that same thing that with hypoxemia, if it's sustained hypoxemia, CPAP may still do well. If there is sustained hypercapnia with transcutaneous CO2 during CPAP titration, that doesn't necessarily mean they're going to fail CPAP in the future. What we need to do is, as you said more eloquently, is try to figure out if we can identify a priori, which are the patients who are going to fail CPAP, which are the patients who are not going to fail CPAP. And by failing CPAP, I mean in the future, they remain symptomatic and they remain significantly hypercapnic, not just trivial hypercapnia. And I think right now, we don't have a good sense to be able to identify these patients ahead of time. So if we don't have a good sense of who are those individuals, then one way to approach the problem is that let's give CPAP a fair shot. And if it fails, and you can define failure whichever way you want, then argue, okay, let's switch them to some more aggressive and more expensive mode of ventilation.
So it's like start with CPAP and then.
Yeah.
And again, that's in the setting of, that would not apply to people who were just recently hospitalized with acute and chronic hypercapnic failure, and also would not apply to people who don't have significant OSA, in my opinion. Because I think people who have significant OSA, seems like OSA is an important contributor, because as you resolve OSA over time, their hypercapnia gets better. And that's why I said, in those individuals, which is a great majority of people with OHS, OSA has to be in the causal pathway of getting hypercapnic, because once you resolve it, they're equally obese right? The body mass is the same,
Mhm.
but the hypercapnia gets resolved during the daytime. So the only thing you really treated, to be honest with you, is you splint the airway open. Sure, as you splint the airway open and you avoid those long apneic episodes, they're breathing. So ventilation gets better, not by virtue of non-invasive ventilation, but by virtue of allowing them to breathe on their own, and maybe improving a little bit of atelectasis and whatnot with the PEEP effect. But yeah, I think in certain cases you may, so I would say if they're getting discharged from the hospital at this point, maybe CPAP is equally good, we just don't know. So most of us are leaning towards non-invasive ventilation. If they don't have significant OSA, most of us are leaning towards non-invasive ventilation. Then you can discuss all this alphabet soup, AVAPs, IVAPs, BiPAP with a backup rate, whatever. And if you put them on CPAP, and despite adequate adherence to CPAP, they remain symptomatic and quite hypercapnic, then I think it would make sense to give non-invasive ventilation a shot.
Okay, very good. Thank you.
Sure.
Omar, you have a question? We'll give you a last shot here, huh?
No, not really. That was really good talk. Thank you. It was full of good information. Probably just wondering about the mechanism of physiology behind the OHS improving with CPAP. Is it just related to the dead space? I mean, in addition to what you've mentioned about the atelectasis and all that.
You mean in terms of CPAP improving these patients over time?
With the hypercapnia?
Yeah. Again, some of these patients that I've seen in the sleep lab, when we have transcutaneous CO2 on them, when I put them on CPAP, what I notice is the airway is splint open, the intermittent hypoxemia, the sawtooth pattern that is classic of OSA goes away. They may have some sustained hypoxemia, but that intermittent nature goes away. And the CO2 levels don't budge too much. To the point that sometimes I tell the techs, maybe the transcutaneous CO2 probe needs to be recalibrated. We've done that many times. It goes in, recalibrates, and the CO2 levels still remain high. And I always wonder, like, what the heck is going on here? I mean, from breath to breath, I think the CO2s are getting better, but the average is not changing much or just goes down a little bit. So I think it's hard for me to say that CPAP has a major impact on ventilation.
Acutely.
Because if it did, you would think that the transcutaneous CO2 would go down dramatically. But the point is, over time, I think by resolving the upper airway obstruction during sleep, somehow, and maybe Kingman knows this better than I know pathophysiologically, the chemoreceptors become more sensitive to CO2 changes, and people have demonstrated this time and again. After 2, 3 weeks, 4 weeks, 5 weeks, that happens. Why it doesn't happen immediately, I don't know. But it does happen over time, at least in the great majority of patients if they're adherent to therapy.
Well, at Goldring and the guys at New York, when they did their studies on hypoventilation, looked at the interbreath interval and whether or not you would, but they thought that, as in Cheyne-Stokes respiration, minute ventilation is about the same over a 5-minute period. So they found if they put them on CPAP, the minute ventilation was the same. You just didn't have these overshoots and then go to apnea. And it depended on the amount of apnea time and the amount of ventilatory time. So I'm really interested in the interapneic interval, number of breaths between an apnea, and then the as well as the apneic length as being a factor. But those are, we measure and we transcutaneous CO2 and tidal we have available, and transcutaneous we have available about, well, we have a working machine about half the beds, so it gets moved around in terms of what we need.
That's better than us. We only have 2.
Yeah, right. So we get to do that. Well, I think we're here about 10, and some people have some clinics, and I want to thank you very much for sticking around afterwards, because that's always
Sure, my pleasure. I enjoyed it.
Thank you.
Thanks, Dr.
Thank
Mokhlesi.
you.
Sure. Have a great day.
All right, so Omar and I now have a virtual clinic at the VA. So he gets on and I Zoom and I listen to him, and that's how we do our virtual tele clinic at the VA. So he and I
That's how uncomfortable it is.
Yeah.
Nice. All right, guys, stay safe.
All right, thank you again.
Bye-bye.